We're joined by Dr. Amesh Adalja. He's an infectious disease expert and senior scholar at Johns Hopkins University Center for Health Security. Dr. Adalja, great to have you with us once again. And let me just start by asking about how we got to this place. And I guess a natural follow-on to that is, what would the U.S. need to do to kind of get beyond this or get back to the way things were? How far is the cat out of the bag?
When you think about outbreaks, sometimes it's hard to understand how things got started. How do you got to the status quo? With measles, it's really a no-brainer. We got there because vaccination rates fell below the herd immunity threshold. And we're talking about what is the most contagious infectious disease that we humans face, one that requires a high level of immunity in the population, and one in which it's circulating in many parts of the world. So all it took was for us to lower our armor, to lower our force field, and then measles came back. It never went away. And the solution is equally simple. It's just to get more vaccine into the arms of people who are unvaccinated, and then this problem will disappear.
David and I have a selfish question. When we were putting this in the lineup yesterday, we've had MMRs as kids. Are we protected? People who had the usual vaccine course as children, does that take you through adulthood? Or at some point, if you're in one of these places with high infection rates, do you need some sort of booster?
For the vast majority of people, the standard 2-dose childhood vaccination schedule will protect them for life. That doesn't mean that the vaccine is 100%, but it's pushing up, above 95%. So there's no generalized recommendation for boosters that are needed for the population. It's really about people who've had 0 doses of measles. That's what's driving this.
In your line of work, a lot of what you deal with is kind of communication about the need for vaccination going forward. And I'm curious, at this moment when it seems like there are government officials who are not promoting them or not advocating for them, maybe it's incumbent more on public health practitioners like yourself to push for that. What is the messaging campaign like? In other words, how do you assess the way in which public health professionals are making the case for vaccines at a time when they seem more necessary than ever?
And what kind of campaigns have been effective? Have you seen any that have worked?
So I think it depends upon why someone is not vaccinated. There may be people who haven't gotten around to getting their children vaccinated. There may be people who have questions about vaccines. So you kind of have to take a different tack depending upon where someone is. And often it's very different to do it kind of as a one-size-fits-all message on television by a talking head versus a provider sitting in front of a patient or a patient's family and asking, what questions do you have about measles? And I think that's the better way to do it. We know that people will move towards vaccination if they can get their answers, get answers to the questions that they have in a non-judgmental way. That's a very different type of rhetoric when you're dealing with the likes of RFK Jr., who is spreading disinformation, where you just have to basically call him out for spreading lies. So it's very kind of nuanced and very personalized, and that's what works. We know that parents trust family doctors, they trust their primary care providers. That's where the actual movement occurs, not so much when someone's on, blasting from a megaphone about the vaccine.
I think we talked about this last time you were on here, but it seems pretty much a fait accompli now that the U.S. is going to lose its measles elimination status. There was this hearing. The U.S. requested that it be pushed back until the fall. So now that decision won't come down until fall. But at this point, can you see any way that doesn't happen given the case rates in the U.S.?
No, I think that the United States has effectively lost its elimination status. And even if by some technicality it maintains its elimination status, the deeper question is, does the United States have resiliency against measles? The answer is no, irrespective of what the elimination status decision is, and there will be politics around the elimination decision. So I think it's just, for all intents and purposes, the U.S. does not have the ability to control measles any longer.
On the issue of control, I'm curious how that dovetails with kind of economic considerations. So when you look at where these outbreaks are, I saw there's one in Teton County in Wyoming, for instance. When you start to see an outbreak like this, so much work has to be done to track down who's been exposed to it, get the word out, obviously mount a vaccination campaign as well. Could you talk a bit about the economic consequences of having a resurgence in a disease like measles in the way in which we're seeing here in the U.S.?
So anytime there's an infectious disease, it will lead to disruption. People can't go about their activities of daily life, which means if it's a child with measles, that child can't go to school, that child's parents might have to stay home, that child's parents might have to hire someone to babysit, and then you have a health department that then has to go and investigate who was the person in touch with. Do they need to contact people? Do they need to do any kind of countermeasures to stop the measles from spreading in a given community? All of that costs money, and it's money that doesn't need to be spent because these measles cases are happening voluntarily by people's choices. This is not some force of nature. This is people's choice to not vaccinate their children, and then it has economic consequences that don't need to be incurred. And I think that's another important point to make with infectious diseases, is that they keep humans from flourishing because they're stuck in bed sick and they're not out there producing, they're out there innovating, and you're taking money that could be used for some other other concern, and now it's being put back to something, it's put into something that we shouldn't have to be putting money into when we've had a solution to this since the 1960s.
Doc, before we let you go, we want to ask you about the other thing a lot of Americans are worried about, and that's this cyclospora going around with this, possibly this tainted lettuce. It seems like, did the government react fast enough? And is this a larger concern about food safety and oversight in the U.S.?
I do think it was more of a reactive reaction from the government. I think state governments did very well, namely Michigan, which got hit very, very hard. But you have to remember that the CDC basically got decimated in this administration in terms of cuts to its budget, whole divisions that were eliminated, including the division that would have been responsible for cyclospora. So there's less people doing this. So when you're thinking about a foodborne outbreak, it's time and speed and the speed to identify what the vehicle is that's spreading something. If you've got less people around to crunch the data, to do the interviews with people who are case patients, it's going to take longer. And the state departments have done well, but they are also underfunded, chronically underfunded, understaffed. So it is something that decreases the overall resiliency to foodborne illnesses when you don't have a robust system in place, or when that system is being actively dismantled.
All right, Dr. Adalja from Johns Hopkins University Center for Health Security, thank you so much for joining us.